Good afternoon, everyone. My name is Matt Downie. I'm the Chief Executive of Crisis. We're just letting a few more people coming, and if you hear lots of dinging, that's because we can't stop that noise, and we just have to wait until everyone's got here. Yes, thank you very much for joining us for this webinar about supporting hidden populations with smoking cessation. We've got 90 minutes or so to hear from a group of experts and to ask some questions. The webinar focuses on supporting hidden populations with insights and solutions from academic partners here with us this afternoon. It's a great chance to hear from them on why we should both care and do something about smoking cessation for people experiencing homelessness and other health inclusion groups. It's going to feature analysis of population data and review of projects developed to engage and support people in those groups. So, and for me personally, this is a vital agenda. Health inequalities experienced by people who are facing homelessness continue to be extreme and much greater than other people. This is not just physical, it's mental health conditions as well. And on average, the average age of death is just 45 for men experiencing homelessness and 43 for women. So, you know, everything is about inequalities and poor outcomes at the moment. Poor mental health is particularly tightly linked to smoking and can provide additional barriers to quitting for people, with heavy use trapping people in a stress of a withdrawal cycle. People with mental health problems often need more support to quit, and this can be even harder to access, of course, if you're experiencing homelessness. And it's worth reminding ourselves that the concept of inclusion health for homelessness, but for other groups, is precisely about the unequal access to the health and support needed in these extreme situations, from registering with a GP to other primary care services. And obviously people without a fixed address can really struggle to make appointments and to receive information and the care that they need. Smoking is obviously a very bad thing for people who are more likely to have other serious health conditions too, including the higher rates of respiratory conditions in the homeless population. And it carries all sorts of other problems like the large financial burden. I'm told that the average smoker is spending at least £2,500 a year on tobacco. So homelessness is a key population for harm reduction and for prevention healthcare to release the pressure on acute services. And really the reasons pile up as to why we should all care and do something about this. But for me, the main reason is that it's also a way to think positively, to boost health, to put money back into people's pockets, and to create the agency, the self-worth, the success stories, the confidence that can be a critical part of someone's journey out of homelessness. So I'm not going to talk anymore. I'm going to introduce people who know far, far more than I do. And to start with, to set the scene for us, we've got Dr. Sharon Cox. So Sharon, over to you.
All right, thanks. And great to hear that, Matthew. Yeah, so I'm just going to set the scene around what we're going to be talking about today and just plant a few seeds in your mind that I'd like you to take with you throughout each of the talks. So for those of you that don't know me, I'm Sharon Cox. I'm a Principal Research Fellow at UCL, and I'm also Deputy Director of Behavioural Research UK. I'm an addiction researcher, but I have a particular interest in poverty and the impact that living in a deprived environment can have on leading people to smoke, but also, more importantly, how being poor and having a really tough life makes it hard to quit or to reduce your smoking. As Matthew alluded to there, smoking plays a huge role in the poor health of inclusion health groups, but it's often seen as the least priority because smoking is what you might see as a silent addiction. The harms come very late in someone's life. Quitting smoking is often something people put off. They think, well, I'll get around to that. And when people have other addictions or housing problems, these are what you might see as quite prominent and noisy health and social issues that take a lot of attention. So what we want to do is not to say necessarily that smoking's more important than any of these other health and social needs, but it is as important, and it does have a contributing factor to people's poor health and sense of well-being. So the three talks today represent three key pieces of work that we've been thinking about and developing for a number of years now to help people reduce smoking. And we're going to be talking about homelessness in two of the talks, but Emma's talk is also going to focus on people who are often missed out, so hidden populations. And we can think of these groups as people that are often missed off the healthcare grid, people who are socially excluded from mainstream healthcare, but nonetheless have many competing health and social needs, and as such end up often receiving support in emergency services rather than our secondary care services. So we all know that smoking's high in this group, up to 80% in some of these groups. And Lynne and Debbie will discuss, as I've said, people experiencing homelessness. Emma will talk about people that are missing from household surveys, some of which are people experiencing homelessness. But what I really wanted to do today was not just talk to you about smoking's high and interventions, because it's tempting when thinking about reducing smoking amongst these populations to only think about intervention studies. And of course, we do need intervention studies. We need to know what's acceptable and what's feasible. But what we really need to do is go beyond interventions alone and think more broadly. So we know that the government has a smoke-free goal. That's less than 5% of the population smoking by 2030, and this is welcome. We need goals, but these targets need to be drawn from the best estimates of the number of people who smoke. So Emma will discuss this in more detail and provide some solutions. But the point around this talk that I want you to take away is that we need better estimates, because we can't monitor or target what we don't capture. And in the time of services being financially and resource tight, capturing smoking status and sharing data is something that we can do better without having too much extra financial or resources to be put into that. We know that the environment in which people live, work and socialise has a cultural context, and for some, smoking is still very, very much part of that cultural context. Some services I go to, it's like going back to the 1980s when it comes to smoking. But even if we cannot tangibly offer smoking cessation support at services, we can change the environment. We can start a conversation. And what we must do is not undermine someone's quit attempt if they've been offered support at another service. So we need policies that help with this, which are both fair and supportive. And Debbie will present a project where we've been developing resources to help with this. And lastly, interventions, I've said, are important. We need to know what might work best, especially when the number of products available is fast growing. And there is now more opportunity, I think, to help people where other methods maybe have not been acceptable or feasible. And so Lynne will present findings from our trial offering e-cigarettes to people experiencing homelessness. So taken together, we hope that something here, at least across these three talks, will be useful to you to help you in your work, or if you're a researcher, to get you thinking about your own populations of interest and how you might work to reduce smoking by different methods. So that's all from me. Thank you.
Thanks, Sharon. So what we're going to do now is move to hear from our experts. We'll hear from each of the three of them for 20 minutes, and we'll have 5 minutes after each person has spoken for any questions from you. So do put questions in the chat. And Elliot, I'm looking to you if we're overwhelmed with questions to maybe highlight some of the ones that we need to make sure are answered. So what I'm going to do is hand over to Emma. And so for those of you that don't know Emma, she is a Deputy Statistics and Methodology Advisor for Addiction and lecturer in Statistics and Quantitative Methods in Epidemiology and Public Health at UCL. Good grief. What an intro. Over to you, Emma.
Thank you. And I think Sharon set some high expectations for my presentation. I think that was a really good summary of what we hope to get out of today. Yeah, my background is mainly in statistics. I do work in tobacco control, so I know a lot about that. I know a lot less about inclusion health, and I think this is where this particular research project came out, was when I started working with an inclusion health team, and they started identifying issues with the population level statistics I was using. And so I thought, well, I use my kind of statistical knowledge to look at this in a bit more detail. So I'm going to be talking today in the next kind of 15 to 20 minutes on the impact of ignoring hidden populations in household surveys. So let's just start with a little bit of information on population level surveys. Some of you will be familiar with them, some of you maybe not so much. So I'm hoping this is at a kind of a a level ground. But population level surveys estimating smoking prevalence are essential for monitoring public health trends and guiding policy development. These surveys also facilitate the efficient allocation of resources by revealing high prevalence groups. Additionally, they enable global comparisons, which allow countries to assess smoking trends and develop strategies to meet international health targets. And they play a crucial role in evaluating the impact of public health interventions. So this includes the success of smoking bans, tobacco control programs, increases in the legal age of sale, and so on. So to start with, I want to make it clear that these population level surveys are valuable and they're needed, but there's issues with them. The main survey for evaluating smoking prevalence in the UK is the annual population level survey. This is conducted by the Office for National Statistics. So when you hear the statistics given in the media on the prevalence of smoking in a particular year, it usually comes from this particular survey. This survey takes place annually on around 320,000 respondents and provides key indicators of smoking behaviour. A smoker, importantly, is defined as someone who currently smokes either daily or occasionally. Over the years, the estimated proportion of people who smoke in the UK has been steadily declining, reflecting the success of public health campaigns, smoking cessation programmes and tobacco control policies. And this decline is evident in the data shown in a particular figure here. So we can see a consistent drop in smoking prevalence since the APS records began in 2011. This slide gives some examples of the impact of the APS prevalence data on policies and public health research. The idea here is just to identify the importance of this before I start to go into some of the issues. So for instance, it's been used to model the impact of several policies, including increasing the legal age of sale year on year. And Sharon just pointed out in her introductory talk on how important it is to have accurate prevalence estimates to conduct such modelling. It has identified that smoking prevalence is more common among certain groups, such as young adults, individuals from lower socioeconomic groups. Researchers have used this data to study the effectiveness of tools like nicotine patches and vaping, for example. And it has been used to look at cross-country differences, including the fact that stricter policies in Scotland and Wales contributed during some years to sharper declines in smoking rates. And finally, it has demonstrated that campaigns such as NHS Smoke Free have boosted cessation rates. But there are concerns. So they've been raised about the representativeness of the APS and other population level surveys to the entire population. And this is in part due to the under-recruitment of hard to reach groups. These groups include vulnerable migrants and sex workers, and they may be difficult to reach due to physical or social barriers. Now, population level surveys use weighting adjustments to account for this non-response, ensuring that the participants reflect similar socio-demographic characteristics as non-respondents. In very simple terms, what this does is ensure that the respondents are representative by increasing the contribution of them to the various estimates. But effective bias reduction does rely on the access to auxiliary information such as health indices and socio-demographic data. And we do need to be aware of the number of individuals who fall in this group and maybe not representative. Now, another group which I'm interested in is known as the hidden population, and these are entirely absent from population level surveys. This group generally lacks defined limits or sampling parameters, meaning that there's no existing sampling frame for them. So this is because the APS is a household survey, and so the probability sampling methods it uses typically excludes individuals in non-private households. Non-private households include communal establishments like care homes, long-stay hospitals, and some groups experiencing homelessness. This includes those sleeping rough, those in temporary accommodation like bed and breakfast. This category also encompasses communities like Gypsy, Roma, and travellers, as well as students in halls of residence. And currently, the APS does not make any adjustments for their exclusion, and so this leads to non-coverage, or what we call coverage error, where the sampling frame does not match the target population. To introduce you to this concept a bit, we've got a diagram here. So this illustrates the concept of non-coverage error in sampling frames, and it shows the relationship between the target population and the sampling frame and the groups excluded from the frame. So the largest square represents the target population. So this is all the individuals for whom the survey aims to estimate smoking prevalence on. So this is the idea that we can actually estimate smoking prevalence on the population that smokes. Within this, we have a smaller overlapping square, which represents the sampling frame. And this is actually the proportion of the target population included in the survey. So those that are residents in private households. Outside the sampling frame, we've got a shaded area which represents excluded groups. And this is our hidden population, so individuals experiencing homelessness, those in prisons, those in temporary accommodation, as well as others admitted to geographic, demographic, or technological barriers. So this diagram highlights how these exclusions create non-coverage error, as the excluded groups may have different characteristics, such as higher smoking rates, which Sharon just mentioned, that differ significantly from the included population. So why is this a problem? Well, hidden populations, such as those living in temporary housing and those experiencing homelessness, make up a significant proportion of the population. And I'm going to give you some estimates in a minute. While these groups are often difficult to fully quantify, estimates suggest that the number of individuals living outside of traditional household settings is substantial and growing. And as these populations expand, surveys that only include individuals in stable housing will become increasingly inadequate in capturing the full extent of smoking behaviour. Moreover, as Sharon's also mentioned in the introduction, smoking rates within these populations are disproportionately high compared to the general population. So studies show that the prevalence of smoking in these groups is often 4 to 8 times greater than those living in households. And these higher rates means that excluding these populations from surveys leads to a significant underestimation of the actual prevalence of smoking in the UK. So imagine a scenario where the general population has a smoking rate of 15%, comprising 90% of the total population, and the hidden population, making up, just for illustrative purposes here, 10%, has a much higher smoking rate of 60%. When both groups are included in the total prevalence calculation, the overall smoking rate actually increases to 19.5%. And this 4.5% increase emphasises the significant impact that hidden populations can have on public health estimates. So this is just for illustrative purposes, and in a moment we will actually look at a true estimate. Ignoring hidden populations is also a problem from kind of inequality perspectives. Hidden populations are disproportionately vulnerable and face significant social, economic, and health challenges. The hidden population is defined by unstable housing and marginalisation. It's frequently overlooked in health research and policy development, leading to incomplete understandings of the true scope of public health issues. And this includes smoking prevalence, among other addictive behaviours. These individuals are more vulnerable to poor health outcomes due to factors like limited access to healthcare, higher exposure to stress and poor living conditions, and they experience many additional challenges. So often these hidden populations face safety risks, including violence, exploitation, insecurity in their living environments. They have limited autonomy. This is often exacerbated by dependency on external support systems, so maybe social services, shelters, or charities. And this further complicates their ability to access care or make decisions that could improve their health. So addressing the needs of this group is essential to ensure that public health interventions are inclusive, equitable, and effective in reducing health disparities across society. But this can only be done if we know the size of this population and the prevalence of smoking within them. So the Office for National Statistics has made several attempts to try and estimate the size of some of these subgroups in the hidden population in the UK. So these include undocumented migrants, individuals experiencing homelessness, and those sleeping rough. The ONS also conducts post-census coverage surveys to try to estimate the undercount of various populations in census data, and this includes ethnic minorities and young adults. However, to date, there is no single published figure for the total hidden population in the UK. So the next question is, why has this not been done before? Well, a significant reason for not fully considering the impact of hidden populations is the fragmented and inconsistent definitions used to describe these groups. Many attempts have only considered people experiencing homelessness and undocumented migrants. Moreover, terms like homelessness can vary widely across different contexts, which complicates efforts to categorise and identify individuals accurately. In addition, there's data gaps, with hidden populations often reluctant to participate in research due to fears of social stigma, legal consequences, or discrimination. And there's ethical concerns around privacy and the potential exposure of sensitive information. Furthermore, there's a very fluid and dynamic nature of hidden populations where individuals move in and out of these groups, and it makes it difficult to track and accurately estimate their size over time. So what is the solution to this? So obviously we can't start asking the ONS to change its survey to include hidden populations, because it needs a different methodology to actually assess the size of these groups and the smoking prevalence within them. One pragmatic and cost-effective approach to address the exclusion of hidden populations from household surveys is deriving and applying what's known as a correction factor. So this method involves adjusting or correcting survey data to account for the estimated hidden population. To ensure statistical robustness, this correction factor can be applied to confidence intervals as well and must be regularly updated to maintain accuracy. But of course, we should recognise that the effectiveness of any correction factor is highly dependent on the quality and availability of data. An alternative approach which has been suggested is to enhance survey coverage by employing mixed modes of data collection, such as combining household surveys with action-based sampling among those using relevant homeless services, including communal establishments in household surveys, and leveraging census weighting and adapting surveys to include temporary household residents. So these are all options, but it's not something that the ONS have said that they would be looking into. There's several costs associated with this, and some of these designs are quite hard to implement. It also disrupts data integrity over time. So the time series that's been collected so far since the ONS was started in 2011 obviously does provide us with trend data, which is very important. A less intensive option involves collecting information on prior inclusion in a hidden population, such as asking respondents about past experiences like sofa surfing. Responses from individuals with such histories can be weighted more heavily to better reflect the hidden population, but this would require complex weighting with a risk of overcompensation. So ensuring that the weighting appropriately reflects the proportion of the hidden population without exaggerating their numbers is difficult and actually would require quite careful calibration and validation. So at the moment, the correction factor appears to be the best way forward. So what we did is we conducted a study, a project, in fact, which was aiming to estimate the size of the hidden population excluded from household surveys. So we actually have an estimate of the number of individuals in this group to determine the potential impact of excluding them on smoking prevalence rates and to derive this correction factor. All this correction factor is a number by which you can multiply the prevalence statistic by to get an overall kind of more accurate estimate. So the ONS non-private household definition was used in this particular study. So this is the definition of hidden population. So this includes people living in a communal establishments, care residential homes, long-stay hospitals, student halls of residence, prisons, and hostels for people experiencing homelessness. It also includes Gypsy, Roma, and travelling communities, immigration detention centres, temporary accommodation, which could be bed and breakfasts or unsupported temporary accommodation, individual sleeping rough, and sofa surfing. So this is the definition that's commonly used. Specific population counts for communal establishments were obtained from official statistics, while estimates for more transient groups, like those in temporary accommodation or sleeping rough, were derived from surveys and reports from homelessness charities and local authorities. Data on Gypsy, Roma, and traveller populations were assessed through community records and specific surveys targeting these populations, while information on immigration detention centres was gathered from government immigration records. So, to get to the results. We estimated that the size of the hidden population in the UK aged 18 plus is around 1.9 million, which reflects 3.5% of the total population. This is comparable to the population of Greater Manchester or Birmingham, meaning that the hidden population in the UK is of a size similar to these large urban areas, highlighting the significant scale of individuals excluded from typical population level surveys. Now, there's a caveat. Of course, this estimate may under or overestimate the true prevalence given biases in the data collection. For example, estimates of rough sleepers and Gypsy, Roma, and traveller communities were more prone to bias, as these groups were harder to track due to their mobility, lack of stable housing, and underreporting in official statistics. Next, we estimated the total proportion of the hidden population who smoke as being somewhere between 58 and 66%. Sharon gave an upper estimate of, I think it was 80% in the introduction there. It is true, and you can see this from the table, that some groups, such as those experiencing homelessness, do have higher estimates. But when we take the hidden population as a whole, it appears to be between kind of 58 and 66%. These two estimates were calculated by weighting the proportions of each subgroup who smoked derived from the previous literature by the contribution of the group of interest in the total population of hidden individuals. So this would suggest that the number of smokers in the hidden population is between approximately 1 and 1.2 million. Again, given biases in data collection, this could be an under or overestimate. So we have to advise some caution here. So what is the impact of this? Well, the annual population survey estimated that in 2022, 12.9% of people aged 18 years and over living in households smoked cigarettes, equating to around 6.8 million individuals. However, when accounting for the excluded hidden population, the number of smokers could be between 7.8 and 8 million individuals. So this indicates an absolute percentage increase in smoking prevalence of between 1.6% to 1.9%. The correction factor, which adjusts for the exclusion of these hidden populations, was estimated at a ratio of 1.12 to 1.15, meaning that smoking prevalence estimates on the APS may be underreported by this amount. Now, this underestimation has significant implications, especially given the UK government's ambitious goal to achieve a smoke-free England by 2030. So we have a target of reducing smoking prevalence to less than 5% for combustible tobacco. The delay in reaching this target is already projected to be approximately 8 years, pushing the target date from 2030 to 2038, based on a projected decline in smoking prevalence of around 0.5 percentage points per year. However, accounting for the hidden population's contribution to smoking rates suggests that the target may be delayed even further, potentially until 2042. Table 4 here presents smoking prevalence estimates for the UK, as derived from the annual population survey. So this breaks down the UK estimate into England, Wales, Scotland, and Northern Ireland. There's also 95% confidence intervals here, which kind of give us the range of values in which the true value likely lies, and adjusted estimates that account for the hidden population using correction factor of 1.15. Now, the data here reveal that the APS estimates for smoking prevalence in England, Wales, Scotland, and Northern Ireland do not overlap with the inflated estimate confidence intervals. This discrepancy, and this is the take-home message, suggests that there is a significant underestimation of smoking prevalence in APS data. So this reinforces the idea that the exclusion of hidden populations is contributing to inaccurate national smoking statistics. Further sensitivity analyses indicated that for the hidden population not to be affected, to not affect prevalence estimates, their size would need to be as small as perhaps 60,000 individuals, assuming a prevalence of 66%. So this would mean that even a relatively small hidden population, much smaller than what we estimated, would still significantly impact overall smoking cessation smoking estimates. So this further emphasises the substantial influence that the hidden population has on national smoking prevalence. So what are the implications? Well, importantly, the goal of these findings is not to disrupt established time series or suggest a change in the method of data collection that have proven valuable in monitoring smoking trends over time. Household surveys have been instrumental in providing consistent and comparable data on smoking prevalence, which is crucial for policy formation and evaluation of public health interventions. Rather, this study is meant to provide a simple statistical tool in the correction factor that can be applied to historical time series. Clearly, there is a need, however, for transparency in informing the public about the limitations of household surveys. The public statistical literacy has notably improved since the COVID pandemic, and there is growing awareness of the complexities involved in data collection methodologies. So it's essential to openly address this by clearly stating that household surveys may not fully represent all segments of society. So what are the next steps? Well, to advance research estimating the size of hidden populations, it's essential to refine data collection methodologies, integrate data across various sectors like health, housing, and social services, and hopefully develop a centralized system for data sharing. Incorporating alternative data collection methods and leveraging big data sources like mobile phone data and social media can also offer deeper insights into hidden populations. There's also a need for a collaborative approach involving governments, NGOs, and academic researchers for building a comprehensive interdisciplinary framework. And moreover, to maintain the accuracy and relevance of population estimates, it's critical to regularly update correction factors and refine estimates. And this might involve more kind of advanced mathematical models to improve precision. I think I did that in my 20 minutes, but does anyone have any questions?
We've got a couple of questions in the chat here, Emma. We've got both from Glenn. So is there anything validating self-reported data, and do communal establishments include armed forces quarters?
Okay, thank you. So is anything validating self-report data? Some of the data most of the data was self-reported. Some of the data was validated, but when we're talking about hidden populations and the means by which we track whether or how many smokers we have, it is quite hard to use kind of validation techniques by asking them to, using CO monitors or coaching or something like that. So most of it was self-reported. Some of it was also reported by kind of a secondary person. So it might have been someone working in the hostel as opposed to the individual. So there were biases in the data. And we will report those in the final publication. In terms of communal establishments, I can't recall off the top of my head, but I believe armed forces were included in the estimates of the number of people living in communal establishments, but they were not adequately, I think, presented for the prevalence of smoking. You can send me an email afterwards and I can confirm that for you. When will this be published? It's under review in Addiction, the Journal of Addiction. I shouldn't say that actually, because if it gets rejected from there, it looks bad, but it's under review in the Journal of Addiction. So hopefully it will be published imminently. Do you know if estimates from other countries include these hidden populations? They don't. So most countries use household surveys and they don't include these hidden populations. And I've had a quick look to see if other countries have tried to estimate the size of hidden populations. There's been quite a few attempts at estimating migrants and also people experiencing homelessness, but not some of these other groups.
Great. I think that's it for questions. Thank you very much, Emma.
Perfect, no problem. Thank you.
Really, really fantastic. Right, we're going to move on to hear from Debbie Robson. So Dr. Debbie Robson is Senior Lecturer in Tobacco Harm Reduction at King's College London. Over to you, Debbie.
Thank you very much. Can you see my slides okay?
Yes.
Brilliant. Okay. Good afternoon, everyone. So I'm going to be talking about development of a co-designed tobacco harm reduction toolkit for use in the homeless sector that myself and Sharon and Lynne have been working on. So I'm a Senior Lecturer in Tobacco Harm Reduction, as Matt said, work at King's and do a lot of collaboration, particularly with Sharon. So what we realised quite a few years ago was that in lots of other areas of health and social care, the specific resources available to help treat tobacco dependence and guide professionals and clients. But when we started to develop this, there was no targeted treatment resources for tobacco harm reduction for staff working in homeless centres. So what we aimed to do was co-develop and co-design a set of resources that helped provide guidance on how staff can engage people with experience of homelessness who use services, any types of services, in conversations about tobacco harm reduction, and provide information about treatment, but also offer some policy templates people could adapt, which were person-centred and transferable across all sectors. So we got some funding from UKRI and the Medical Research Council. So the DITCH team involves me and Sharon and Lynne and two research assistants, Dorothy and Vlad. And we've also acknowledged funders from other studies that have informed the toolkit, such as Cancer Research UK and the National Institute for Health and Care Research. In terms of disclosures, I'm a trustee of ASH, and the images of people that we use in this presentation are for the Centre of Homelessness Impact. And also like to acknowledge the services that helped us contribute to the toolkit. So I'm going to give you an example, overview of how we developed it, what service users and staff said they wanted in it, and some examples of what's actually in it. So in terms of how we've developed it, we've taken the learning from our collective previous studies in this space and our clinical experience of tobacco harm reduction involving the homeless, mental health and drug and alcohol sector. And for this project, we used experience-based co-design and used focus groups and interviews with staff working in the homeless sector and service users, and we recruited participants from 6 different organisations. And we've had one-to-one interviews, we've had focus groups, we've had workshops with 24 service users and 20 staff. And in line with our research methodology, Sharon and I produced a short film about smoking, and we showed the film at the start of the focus group and individual interviews to prompt a discussion and elicit what's called touch points. So things that would somehow evoke some kind of emotion. And we asked service users and we asked staff 4 broad questions. So what's your understanding and your past experience of tobacco harm reduction? What does good tobacco harm reduction support look and feel like? What would or does an effective and compassionate tobacco harm reduction policy look and feel like? And also we got some guidance on language to use. And our qualitative researchers, they supported us with the coding of the interviews. So what service users said about their past experience of treatment, most of them couldn't recall being asked about smoking, and they thought that staff either didn't believe they could quit or they were too busy to discuss it. So James, who's a service user, said, we just don't really talk about it. And I don't know why, because we talk about other things. They always talk to me about my diet and how I plan my money. But even when we talk about me spending more money on food and less money on other things, no one ever mentions my smoking and how I can spend less money on my tabs. Several people had tried to quit without support, but they'd also tried nicotine replacement therapy and e-cigarettes. Many people didn't find nicotine replacement therapy effective. People had started vaping, but they stopped vaping because they couldn't afford to continue it, or they struggled with their devices and really wanted more instructions about how to use vapes. And a lot of people were hindered by being in environments where their peers and staff smoked. So Lily said, there's no point in trying to quit because you just come out of your room and boom, smoke's everywhere. In terms of what does good tobacco harm reduction support look and feel like, what service users said was it would be delivered by support workers, preferably at the service user's accommodation. What they didn't want to do was schlep off to another service across town and be amongst other people that didn't have the same experiences of them. Timing needed to be right, and they said they wanted to be offered this when they were stable and not when they were feeling low. So, for example, Kizzy said, when I first came to this place, I just wasn't making eye contact with any of them. You could have offered me anything and I wouldn't have taken it up because I felt so ashamed at being here and I didn't even want to look at you. Once I felt safe and started working and feeding myself, yeah, then offer me support. I'll take whatever you got because I'm ready to receive it. They also wanted support that included strategies such as achievable goal setting, somebody to talk to, preferably not online, resources in various formats, so printed, graphics, brief videos, and integrated into kind of routine care with support workers, so less formal, so during a walk or over a cup of tea. In terms of what effective and compassionate tobacco harm reduction policy looks like, service users said it needs to be motivating, it needs to be respectful, it needs to be collaborative. We respect non-smoking policies in communal areas, but please allow us to smoke in our accommodation, which is a tension with some services. And just show us you care. And Brian said, it's not hard, just speak to me. Speak to me like we're equal. Don't look down on us. Don't feel sorry for us. Don't pity me, because that annoys me. And he said, you just get used to people thinking you're hard work. You've got lots of needs and they'll probably just let you, you know, smoke, drink and smoke and whatever, because you're just hard work. And what staff said good tobacco harm reduction support looks and feels like is it would be tailored to support the individual needs. We need resources. We need nicotine replacement therapy. We need vapes. We need CO monitors. We need materials in different formats. We need different resources to give people for coping strategies. We need much more peer mentoring, and we need to know much more about the effect of smoking and stopping smoking on mental health. They wanted to be collaborative with other service providers. They wanted education of community stop smoking services and how to communicate with service users they worked with, but also manage expectations of smoking cessation services and take away the barriers and take away the restrictions to access and services. And they wanted generally everybody to be much patient to clients on their tobacco harm reduction journey and celebrate the small wins, even if it's just not smoking for a few hours, not just the big end goals. And everybody wanted training. So Robert, who worked in a residential centre, said, I know what I'm doing with drug harm reduction because I've been saying it for years, because it's written down everywhere. And for tobacco harm reduction, it's like the blind leading the blind. And it just would be so good to have something to refer to. So I know what I'm saying is the right thing. So we had lots and lots of suggestions from service users, from staff, and lots of overlap. So both staff and service users largely wanted the same things. There was a few things like somebody wanted an app. Somebody wanted much more instructions about how you use NRT and vapes, lots of information about physical health, and just lots of different types of materials. So in terms of what is going into the toolkit, so we're going to have a place where you've got resources in one place and you'll be able to link to it from multiple different sources. People will have a choice of how they view and use these resources. So some people can have hard copies. It can be seen on a mobile device. You can access it via your desktop. And then we'll also have a page where we've collected all sorts of existing resources and training into one place that you can link to. So we've developed information sheets and conversation guides. So we've been writing stuff on nicotine pouch user guides and information on secondhand smoking and how that impacts other people in services. We've got policy templates and considerations for how you develop a policy. And what we're also doing is collecting good examples of policies, and we're going to have a policy repository. And then we've got some best practice guides. So this is just an example about expectations about exchanging information. So what should services be telling a stop smoking service? What should the stop smoking service be telling services such as mental health services or services that are people accessing who are experiencing homelessness? So for example, everybody needs to know about the prescribed medication that people are taking. And the potential interactions of smoking and stopping smoking. And I've been contacted by lots of people at the moment from different parts of the country who are really struggling because everyone's passing the buck on this, and no one's really nailing down whose responsibility is it to monitor people's medication and inform everybody about it. So hopefully that will be a useful resource. And then we've got links to existing other resources like Groundswell are doing some brilliant work in this space. ASH have fact sheets, briefings, webinars on everything to do with health inequalities and smoking. And then the CSCT is a great resource, and they've got a very brief advice, brief training video for homeless services that Sharon and I contributed to a couple of years ago. And so I'm going to give the last word to Simon, a residential worker who participated in the study. And he said, I'm sure I speak for the whole team when they say we worry that we're going to tip people over the edge and how we manage their smoking. So having some proper guidance on what to offer people at different stages of their recovery and how to get someone back on track with their smoking reduction would be so valuable. So the whole Ditch team really hopes that this is it. This is the proper guidance that will hopefully be so valuable. So thank you from our collaborators. And thank you to all the people that participated in the research.
Brilliant. Thank you, Debbie. There's so much that resonates there from my perspective. but I'll hand over for our question in the chat, which is, how do you intend to measure and evaluate the effectiveness of the toolkit?
So we built in some evaluation to the toolkit. The grant we got from the UKRI and MRC, it's for potentially developing interventions that might not actually make it to the implementation stage, but we think we're not far off the implementation stage here. So we've got a few services that are happy to try it out, and then we'll do some kind of brief surveys and more focus groups and interviews.
Great, thank you. And when is the toolkit likely to be ready for us to access?
Probably in a couple of months.
Okay, there you go. I'm going to abuse my position and ask about one other thing, which is I was really struck by some of those quotes from people with lived experience, and in particular that the way in which homelessness services are provided can often reinforce a parent-child dynamic, and the rules and the kind of regimes of hostels and those sorts of residential settings, and the way in which people are being asked to be treated like an adult. And I wonder how that interplays with your analysis here, because from our perspective, the more that, generally speaking, relationships are equal, the faster the journey out of homelessness, let alone everything else alongside it.
Yeah, and I think that's the same in mental health care and drug and alcohol services. But the fact that, in 2020, we did these interviews 2024, 2023, the fact that people are still having to say, just show us that you care, show us some respect, be collaborative with us, it's a bit sad, really, that they're having to tell us to do that.
Yeah. Absolutely, yes. Well, thank you so much, Debbie. And I can see there's lots and lots of love and interest in what you're doing. So really, really appreciate it. Next, we're going to move on to hear from Lynne Dawkins, Professor Lynne Dawkins, who is Professor of Nicotine and Tobacco Studies at the London South Bank University. Lynne, over to you.
Hi, can you see me and hear me?
Yes and yes.
Okay. And can you see my slides?
Yes.
Great. Hi, everyone. Thank you for that introduction. And thanks to the other speakers so far. It's really set the scene quite nicely for this third talk on what we can actually do in terms of interventions in centres. So I'm Lynne Dawkins, Professor of Nicotine and Tobacco Research at London South Bank, and I'm going to talk about the main findings from our smoking cessation trial, where we offered an e-cigarette starter kit to people experiencing homelessness. And this is work done with Sharon Cox as co-PI and with a much wider team, including Debbie as well. And just want to acknowledge the NIHR for funding this trial. So by way of background, there actually hasn't been a lot of research until the last few years on smoking cessation amongst people experiencing homelessness. Much of the work that has been conducted has been done in the United States. There's been a little bit of work in Australia, but hardly anything until we started working in this area across Europe. And even fewer trials, in fact. The trials that have been conducted, again, mostly from the US, show very low success rates among people experiencing homelessness, and generally only focus on short-term quitting. They don't tend to look at long-term sustained abstinence over longer periods, such as 6 months to a year. And at the time we started conceiving of this trial, there had been no intervention studies that had included an e-cigarette. And given that we know that e-cigarettes are hugely popular amongst people who smoke in the general population and are one of the most effective tools for smoking cessation, we wanted to explore whether this might be a more effective method amongst people experiencing homelessness than some of the other NRT and other things that had been tried to date. So before we embarked on this trial, we did quite a lot of background work. We did some scoping work. We spoke with people experiencing homelessness and with those who support them. And we found that there is interest in quitting smoking. It's often thought that people experiencing homelessness and with other disadvantages are not interested in quitting. That clearly isn't the case. There were plenty of attempts to try to quit smoking in the past, but success rates were low, and there was interest in trying e-cigarettes and willingness to take part in research. But we were also told, and this overlaps what Debbie was saying earlier, that people just don't want to be sent somewhere else to get support to help them quit smoking. They're already having to travel to lots of different places for lots of different appointments. So if we can bring an intervention in-house to a location where people are already accessing other support to get a meal or to get a shower and so on, that was certainly more favourable. And in addition, people told us that they would like the intervention to be delivered by people known to them and trusted by them. So that was all really important scoping work. So our intervention was the provision of a free e-cigarette starter kit provided at centres where people were already accessing services. We tried out various different devices in the early stages with people experiencing homelessness, and we settled on this one, which was generally reported to be the most reliable, satisfying and easy to use. It was the the Aspire POC-X, which importantly is not funded by tobacco industry. It's a completely independent e-cigarette company. So we gave the starter kit with a charger pack and 4 weeks supply of e-liquid that was given out by staff in centres on a weekly basis. And importantly, to mirror what people do in the real world, we offered a range of different flavours, a range of strengths. The idea was that people could try these out at the beginning and then switch or mix and match or go up and down in nicotine concentration over that 4 week supply period. We also gave out a support leaflet to help people to transition from smoking to vaping. Then our control group was usual care. Usual care actually differs widely from centre to centre and in the different devolved nations and from area to area. But generally it comprises signposting to the local stop smoking service. So this was what we did for usual care, but we went a little bit above and beyond that. And we also adapted the NHS Choices Help to Quit Smoking leaflet, and the details and signposting to the local stop smoking service were provided on that leaflet, and staff were able to help facilitate that if required. So it was delivered by staff, and we started by training the staff in centres. The training was developed by Debbie and was very well received by the staff in centres. For the usual care group, they were trained in VBA+, so very brief advice, and staff in the e-cigarette group were given that same kind of background information about smoking and the importance of quitting in this population. But in addition to that, they were also given information about e-cigarettes, some of the myths around e-cigarettes, how to support people attending the centres to use them, to charge them, and then of course how to deliver the e-cigarette intervention in the context of this trial. And importantly, by offering that training and support to staff, they were not only able to support the usual care and the e-cigarette intervention in the trial, but take that learning and knowledge forward and to support people beyond the scope of the trial. Our trial was what we call a cluster trial. So this means instead of randomly allocating individuals in centres to either receive the e-cigarette intervention or usual care, we allocated the centres as a whole. So a whole centre would be allocated to either the e-cigarette intervention or usual care. And this was because very early on, staff and clients attending centres told us that it wouldn't work to offer one person an e-cigarette starter kit and signpost another person within the same centre to the Stop Smoking service. That would cause disharmony, feelings of unfairness, but also possibly sharing of the e-cigarette and perhaps stealing and so on. But also, more importantly, if this was to roll out across the country, then it would be rolled out at a centre level, not at an individual level. Our centres came from across Great Britain, so from Scotland, Wales and England, and we had a target of 32 centres and a target of 480 people attending those centres. So that's an average of 15 per centre or per cluster. So just want to take a step back a bit from the trial, because we wanted to make sure before we embarked on this main trial that we could actually recruit people to take part, that people who were given an e-cigarette were able to kind of keep hold of it and not lose it or break it or have it stolen, that staff were able to support the study, and importantly, that we could actually keep in touch with people and follow them up and collect data over a 24-week period. So we did this feasibility study in just 4 centres to check those things, and that all went pretty well. We found that half of all eligible people who were asked did in fact take part. The majority still had their e-cigarette at 12 weeks, and quite a few still at 24 weeks, some of whom actually went on to buy their own. The follow-up rates were pretty good, so 59% were still in contact with us and provided follow-up data at 24 weeks, which is consistent or better than other trials in this area. And then finally, in this feasibility study, we wanted to just capture the longer-term 24-week quit rates, so we could work out what sample size we would need in our main trial. So coming back to the main trial, we wanted to find out the proportion of those in each group, the e-cigarette group and the usual care group, who firstly managed to completely stop smoking through to 24 weeks, so our longer-term sustained abstinence. We also wanted to look at shorter-term quits, so this is more in keeping with previous trials that have just focused on short-term quitting for at least 7 days. So we looked at that at each of our follow-up time points. And then perhaps a more realistic goal for many people was to look at smoking reduction rather than complete quitting. So we looked at that as well, and the proportion in each group who had reduced the number of cigarettes they smoked from the beginning of the study to each follow-up point by at least half. We also see documented in the literature reports of people experiencing homelessness engaging in these kind of so-called risky smoking practices. So this might include sharing cigarettes by passing it between 2 or more people, or picking up discarded cigarette ends and smoking them or re-rolling them, or asking strangers for cigarettes. So we captured information about that over time and across groups too. And finally, we looked at the cost of the intervention. We also included a really comprehensive mixed methods process evaluation. So the above questions in bold kind of tell us the what, but the process evaluation delved into the how. So if there's any change in smoking behaviour, how does this occur? What are the contextual factors? What are the mechanisms? But unfortunately, today I don't have time to go into that aspect. So here's our trial timeline. So we started with recruiting centres, and then our trials unit, once the centre had confirmed that they were willing to participate, our trials unit randomly allocated that centre to either the e-cigarette intervention or to usual care. And then we as a team went in and trained the staff in those centres according to their allocation to either the e-cigarette or to the usual care group. What's important at this stage is we wanted to avoid recruitment bias. That is where participants in centres only take part because they know that they are going to be in the e-cigarette arm. So before we even informed the centres of which condition they had been allocated to, we gave expressions of interest posters to the centres, so they could put the posters up for people interested in taking part in a study about their smoking before they knew which group they had been allocated to. And there was varying levels of success with that. So after we had trained staff and informed them which group they had been allocated to, within 2 weeks of that time point, we started recruiting participants, and then a research assistant completed the baseline assessment and then told the participant which group they were in, either the e-cigarette or the usual care, in accordance with the cluster that they were part of, and then passed them over to a member of staff to deliver the e-cigarette or the usual care intervention. And then we conducted follow-ups in centres at 4 weeks, 12 weeks and 24 weeks to collect outcome data. These little boxes above and below in the salmon kind of colour are related to our process evaluation, which, as I said, I don't have time to cover today. A busy slide, I know. This is the participant flow throughout the stages of our trial, but there's just a few key points that I want to cover here. Firstly, in terms of inclusion criteria, we had a very broad inclusion criteria. So to be eligible, participants just had to be a smoker. They had to be known to the centre staff, but they didn't necessarily have to be motivated to quit. And there was no exclusion for not being able to speak English, or for having a mental health diagnosis, or for drug and alcohol use. So we wanted to make this as inclusive as possible and to represent this population as closely as we could. Of the people assessed for eligibility, 67% were enrolled in the study. We did see some kind of dropouts over time, which is typical of any trial. And this was more so in our usual care group than in our e-cigarette group. And then our analysis was intention to treat. So everyone who was randomly allocated was included in the analysis, apart from one person who withdrew consent and another person who unfortunately passed away. But of those who we couldn't follow up, as with other smoking cessation trials, we regarded them as still smoking. We were successful in recruiting all 32 centres. And in terms of participant recruitment, you might remember our target was 480, so we were just 3 short of that. We translated study materials into 12 different languages. That includes Welsh and several others. And our follow-up rates were pretty good and actually quite consistent with what we found in our feasibility study. Participant characteristics, quite representative, I think, of what you might expect for this population, an average of 44 years, predominantly male and white, a high number on benefits, and high rates of reports of physical, mental illness, drinking alcohol, and use of other drugs. And we, at baseline, the average number of cigarettes smoked per day was reported as 15, with an average carbon monoxide breath test of 16 parts per million and a score of 5.3 on average on the Fagerstrom test of cigarette dependence. So moving on now to the main findings. So starting with our long-term quitting. So this is uninterrupted quitting from baseline through to 24 weeks, which was carbon monoxide validated. So this was a really strict strict abstinence criteria. So participants not only had to self-report and have a carbon monoxide validated breath test at 24 weeks, but they had to have a carbon monoxide validated breath test, so below 8 parts per million at 4 weeks and 12 weeks and 24 weeks to be regarded as a sustained abstainer. So we can see here the numbers are low. We have 5 quits in the e-cigarette arm and 2 quits in the usual care arm. So that is 2.1 versus 0.8% quit. This, as you might remember from the earlier slide, is lower than we found in our feasibility study. So actually, we can't really conclude that there is a difference between groups. There's uncertainty here in the primary outcome. Moving on to look at the short-term quit rates. So this is the percentage that reported not smoking at all in the last 7 days, again SCeTCH validated at each follow-up time point, 4, 12 and 24 weeks. And here we can see consistently higher quit rates in the e-cigarette arm shown in blue compared to usual care shown in yellow. And this increased over time, reaching statistical significance at the 24-week time point. And then our final outcome relating to cessation and reduction was at least a 50% reduction in smoking. So this is calculated from the reduction in smoking from baseline. And although I say at least 50%, for many people, this was a big smoking reduction. This was maybe more than 80%. And again, consistently, the reduction was greater in the e-cigarette group compared to the usual care group at all time points. Moving on to risky smoking practices. So this includes sharing cigarettes, smoking discarded cigarettes, and asking strangers for cigarettes. At baseline, the most common answer to this was not at all, I don't do this. But between 20 and 50% reported engaging in these behaviours at least occasionally. And the most common one, was reported by 50% at least occasionally, was sharing cigarettes, often referred to as going twos, with around 30% reporting asking strangers and 20% reported smoking discarded cigarettes. But what happened to that over time? We saw no difference over time in asking strangers for cigarettes, but for the other two, sharing cigarettes and smoking discarded cigarettes, we saw a significant reduction in the percentage reporting that they engaged in these behaviours, but that did not differ according to whether they were in the e-cigarette or the usual care group. And then finally, I just want to cover the costs. So these are the costs per participant for the e-cigarette group and the usual care group. Starting with treatment costs. So treatment costs are the cost to deliver. So this includes the costs of the e-cigarettes and the liquids, the fact sheets that we gave out, and the costs for the staff time delivering the intervention and the staff training. So those kind of direct costs, which, as you might imagine, were higher for the e-cigarette arm. The smoking cessation costs includes the treatment costs, but also the extra smoking cessation costs, which might be visits to the stop smoking service, products provided by GPs, pharmacies, stop smoking service, and so on. And again, that is slightly higher in the e-cigarette than the usual care arm. When we come to look at cost per quit, now cost per quit is based on the SCeTCH validated long-term sustained abstinence rate, and there were few of these, so the cost per quit was very high in both groups, but lower in the e-cigarette group because there were more quits in that group. And then finally, when we expand this even further and we look at the total costs, so this now includes a kind of a societal approach where we include any costs of access to primary, secondary service, community care, emergency services, things like products that the participants might have bought themselves, lost income, and so on. We're now seeing even higher costs, and again, higher in the e-cigarette arm. And this simply reflects just more participants in the e-cigarette arm who accessed emergency services during the course of the trial for whatever reason. So again, these data are uncertain, and it may be with a different sample that we see something different there. So to conclude then, even in a sample that were not motivated to quit, we did find that short-term quitting and a reduction in smoking is possible amongst people experiencing homelessness, and this was more common in those who were using an e-cigarette compared to usual care. However, the sustained abstinence was difficult to achieve, and we saw very low quit rates that were sustained across that 24-week period. And this was lower than we had anticipated based on our feasibility study findings, where the quit rate was 6% compared to 2% here. So we had reduced power to detect an effect. So our sample size simply wasn't big enough. So there's uncertainty there. And because the sustained abstinence rates were so low, the associated cost per quit was high. On the plus side, we have found again that it is possible to engage with both staff and clients accessing homeless services. There is interest in addressing smoking, and there is interest in using an e-cigarette. However, just providing an e-cigarette with quite a minimal level of support, as was the case in our trial, is probably not enough to support longer term quitting, and additional support is clearly needed here. So to finalise, I just want to thank the whole study team. I mean, this was a huge trial. It really was a team effort, led by Kirsty Saw, who managed the project superbly, our area leads, Alison, Rachel and Caitlin, who managed the England, Scotland and Wales sites, as well as all the research assistants and the extended team, and of course our participants and the 32 services that took part. We can't name all of them here, so this is just some of them. So thanks very much.
Thank you, Lynne. That's really inspiring, and it's wonderful to see such positive results. The question here from Laura is, do you have any thoughts on why the long-term quit rates were lower than expected?
Yeah, let me try and come back to this so I can see. Well, yeah, this is an interesting one, and it actually often happens that you might see something quite positive in a feasibility study, but then when you roll it out at scale, you can't maintain that kind of high level. It's all very well in retrospect, isn't it? But I think there's a couple of reasons. I think, firstly, in our feasibility study, there was one centre in the e-cigarette arm that was just really very much on board. And we did see a real change in the kind of the centre ethos there. We were able to give out more than 15 e-cigarettes in that centre as well, which we were restricted to in the main trial for statistical purposes and clustering. We had to restrict the number of people that were recruited in each centre. So perhaps we just didn't see that whole systems level change. And in that feasibility study, some of the staff that were smokers also switched to vaping, and it very much became a vaping culture. Whereas we see from the process evaluation that I haven't had time to discuss today, that one of the things the participants were saying in this trial was there was still very much that smoking ethos in centres. They didn't see many people around them vaping. So
okay,
those are my thoughts.
Thank you, Lynne. Now, Sharon, I wonder if I can bring you back in at this stage. Are you still there?
I'm here.
Excellent. Great. So firstly, really, if you've got any concluding thoughts from what you've heard, but also there are some, I think, some more general questions in the chat here. I'm not sure if they're general because I'm not an expert in the field, but there's one here. Could services be encouraged to use more Section 31 money to do more outreach on this? I'm not totally sure what Section 31 money is, so I wasn't sure who to ask that question to. But there's also a question about informing the tobacco control level, and I wasn't totally sure what that one meant either. So I'm relying on you to interpret what those questions mean and give us any wrap up thoughts. Thank you.
Okay, yeah. So I'm just going to put my earpods in actually because I do share an office. So just give us a second.
Can't hear you. No.
I could jump in answer Louise's question
Okay.
Yeah, please do.
Section 31 while Sharon's sorting their ears out. So in terms of this Section 31 public health grant that pays for community stop smoking services, we're just doing an evaluation at King's around Swap to Stop, how that's going, and the extra £70 million a year that's been invested into stop smoking services. And we're looking particularly at how are services spending their money is it going to targeted on kind of groups that are traditionally neglected? And it seems a lot of services are using the additional funding to help people who experience homelessness and mental health problems and drug and alcohol problems. So you're seeing a lot of innovative work with the extra investment into stop smoking services. Over to you, Sharon.
Yeah, can you hear me now?
Yeah.
Yeah.
Okay, sorry, my laptop just hates me. Okay, so yeah, just to expand on what Debbie said, really, we do know that at a local level, there are many projects happening. You know, those of us on the call who presented today have, you know, we're often asked at a local authority level to have one-to-one. So we know that there's a lot going on. There is, however, no evaluation of these at a national level, and there's very little in terms of joined up learning, and that's a shame, and we have to think about ways that we can do that. But moving forward, there is still a place for stop smoking services. I think something that we've very much learned is that staff that work in the third sector agencies are really pushed. They are dealing with a broad range of health and social needs. So there is, I think, a role for the stop smoking services to be reimagined for the future and to be placed within these services. Just one thing I would like to just add is that, you know, we often talk about these groups as hard to reach, and what we've meant by that, I think, is that they're hard to reach because they don't walk into the stop smoking service. But actually, as Lynne's study shown, you know, recruiting nearly 500 people accessing homeless services, if you take services out to people, they are interested. So yes, so in terms of Louise's question, it's about where is that money now best spent, and it needs to be, I think, more joined up thinking between these third sector agencies and the stop smoking services. The problem is that, you know, the third sector agencies operate outside of local authorities and the NHS, so that does need a sort of coordinating force really to bring those together.
Wonderful. Okay. Well, I think that's the end of our questions and the contributions from our wonderful contributors. It's been a real learning journey for me, this, and I've really
Can I just
valued it. Yeah,
Can
Sharon,
I just
go
pick
ahead.
up on another point? Sorry.
Yeah.
Somebody said vapes are also vital for relapse prevention. The talk of only for cessation misses this point. That's absolutely true. But I think I'm not sure if we've maybe in this webinar talked about cessation as if that's, you know, the only role for e-cigarettes or other types of nicotine replacements. But at the moment, we don't have enough people quitting smoking to be thinking necessarily about relapse prevention. That would be great, and that would be the dream. And there are people that, you know, these products will have a role for relapse prevention, and we've got so much to lean on in terms of other drugs in terms of relapse prevention that shouldn't be too arduous. But at the moment, we're just not even at the position where we've got enough ex-smokers to be using that type of language. So that's sort of the dream, really, when we can get there.
Understood. Thank you. All right. Well, I hope everyone's as informed and inspired as I am, and all of this will be sent out. There's recording, there's slides to go out to everyone, and so just a huge thank you to Emma, to Debbie, to Lynne, and to you, Sharon, and thanks for having me. And I think that's the end of our webinar. Thank you.
Thank you.
Thank you.
Thanks. Bye.